quick tip for you guys. You'll see here that
if you go back to the page.
the first one is
Okay. Hello, everyone. Welcome to our 58th webinar. It's nice to gather again. As all of you may know, I'm Dr. Park, the director of WEBCEPH X. Before we start the webinar, please take note of this. Thankfully, the WEBCEPH X webinar series was able to happen all because of our speakers who shared their knowledge with us for free. All the rights related to the webinar belongs to our speaker. So please do not record the lecture with your own device. Thank you. Today we have invited Dr. Johnny Liaw, and he will give a lecture regarding orthodontic turning points from failure to success, the key to orthodontic success. He has DDS degree from School of Dentistry, National Taiwan University, MS Graduate Institute of Dental and Craniofacial Science, Chang Gung University. I'm president of Taiwan Association of Orthodontics, 2013 and 2014, and chair of Taiwan Board of Orthodontics, 2015 and 2016. Wow. Hi, doctor. Can you hear me? For a while, he's connecting. Yes, can you hear me? Yeah, yes. I can hear you. Hi again.
Thank you. Thank you so much for your kind introduction.
Yeah, thank you for allowing your precious time to share a lecture with us today. A lot of members have gathered today for this webinar through Zoom, about 6 members, and many of them through the YouTube channel. And thank you for your presence. And I'd like to introduce the 2 panelists who thankfully attended our webinar, Dr. Yang Kim and Dr. Min-Seok Chang. Hi.
Hi. Hello, nice to meet you. It's an honor to meet you. Thank you for giving us a great presentation. Thank you.
My pleasure.
Great. And thankfully, with the permission of our speaker, this lecture will be streamed in YouTube and Zoom channel. And after that, if you have any questions, kindly send me a private message through the chat box of Zoom or leave it down to the YouTube channel. Then doctor will answer them after the lecture. Okay, are you ready, doctor?
Yes.
Yeah. Okay, have a great time through this lecture. You may start now. Please share your screen. Okay. Can you change the presentation to full version? Yeah, it works.
Okay. So first of all, I thank Dr. Park's invitation, and I'm very excited to share my materials with all the colleagues. The topic I'm going to share today is orthodontic turning point from failure to success. I'm Johnny Liaw. I'm from National Taiwan University and also from Taiwan Association of Orthodontists. Just like to give you an idea where Taiwan is. Taiwan is a small, beautiful island surrounded by China, Korea, Philippines, and Japan. And the city I stay is Taipei, which is the capital of Taiwan, and also where the highest building, the Taipei 101, is located. As an orthodontist, the Taipei 101 looks like a minuscule to me. I hope I can convince you the value of tests in our daily practice. Excuse me, can we minimize, okay, the here? Okay. Again, I'd like to extend my most sincere gratitude to the organizer, Dr. Park, for his kind invitation, and also this opportunity to share my materials with all the colleagues. back to my topic today. I like to focus on some critical decision making in our daily practice. Here this is the theme of 2020 TAO annual conference. Actually, after the last overseas international conference I have attended is 2020 annual meeting in Portland, United States. After that, it seems everything locked down. And AO annual meeting is the first to go virtual. The first ever in AO history. And after WIOC in 2019, the 2020 WIOC originally was planned to be held in Peking, China, but it was disappeared without any announcement. The ninth IOC in Yokohama, Japan, at last go virtual in the end. So everything seems locked down. It makes me recall all the orthodontic journey in my past decades. I recall all the wonderful experience in so many international conferences, not only vibrant scientific program, but also beautiful sceneries and warm friendships in various locations in different countries. So when I got this invitation from WEBCEPH, I decided to review all the topics I have gave in the past and decided to present an essentials of my past presentations. So here I have the orthodontic turning point from failure to success for you. And I'm trying to focus on the critical parts, the most critical parts, which lead to success instead of failure. Because I think orthodontic treatment is all about countless decisions made in every appointment. Just like everyone's life, it's all about countless decisions made in everyone's journey. It was 2000. It was 2000 when Dr. Zhang Lin invited Dr. Hee-Moon Kyung to give the first TED presentation in Taiwan. And after that, Taiwan is lucky enough to host the third AIOC and the sixth AIOC and the second WIOC, the World Implant Orthodontic Conference. So after that, the third WIOC was held in Verona, Italy. And I spoke on total arch digitization with TESS. Here we have the first our first case today. She was a low angle class 2 division 1. We know this kind of low angle case usually have strong muscle, and which make the tooth movement more difficult than average manual plane angle. So I try to use tests to digitalize the whole upper arch, trying to avoid extraction to improve her protrusive profile. Here we have, you can see the upper posterior tests were installed to retract the canine to digitalize the whole upper arch. And in addition to upper posterior test, I also installed the lower posterior test to upright the lower incisors, because if we do not upright the lower incisors, there is no room, no overjet for us to retract the upper incisors. And one more thing we need to know, we need to open the deep bite before overjet reduction. So I installed the anterior test in the lower arch between two central incisors so that I can distalize upper and lower at the same time while I open the deep bite. And here is the treatment comparison. Without extraction, we can improve this protrusion by total arch distalization. And with 4 tests at 4 quadrants, we can easily correct the dental midline. And you may notice the smile view. We can see the smile improved, the incisor show improved, because the torque of upper incisor were too proclined. So we need to upright the upper incisors to improve the incisor show. And that's why I installed the lower anterior test instead of upper anterior test. And here is the supplementary superposition. You can see no extraction, but we can distalize the upper arch by 4 millimeters at molars and 8.8 millimeter at incisors. And here is 10 years follow-up. The profile look stable, no problem. So you can understand with the help of tests, we can do total arch distalization in class 2, especially for low angle cases, because we do not want to extract. How about class 2 division 2? You can see a protrusion class low angle case with a gummy smile, and the deep overbite was over 100%. So again, I use upper posterior test for class 2 correction and anterior test for bite opening and gummy smile correction. Together with the bite table here to disocclude when we bond the lower brackets. We use an upper posterior test for class 2 correction and the anterior test to open the deep bite successfully. My preference for the anterior test is subapical. With the anterior test, you can see we can open the deep bite like this and reveal the worn incisor edge so that you can restore the worn incisor edge. At the same time, we can use the upper posterior test to distalize the upper arch to correct the class 2 canine relationships. And here is before and after. Before and after. The torque was well controlled. Before and after. The molar relationship were complete class 1, very solid class 1. And also the facial profile was improved. And the gummy smile was corrected. I'd like to thank a good friend, Dr. Ramsey from Thailand. He drew this illustration to show the combined intrusion and retraction force system for this case. And he also drew the supplementary superposition to show the treatment changes. We can see the total arch distalization in the upper arch so that we can reduce the facial profile. With the incisor intrusion, we can also correct the gummy smile. Without extraction, the upper arch was distalized in mass. in addition to the torque band in the incisor slots, we also use upper anterior test. We can intrude the upper incisor, but at the same time, we got a counterclockwise rotation. I mean the counterclockwise moment, which means plateau root torque for this case. So we can correct the class 2 dip 2, the retroclination of the upper incisors. So total arch desization with TAS also works well in class 2 division 2 cases. But I'd like to show you another class 2 division 2 case, which did not go so smoothly. Again, a low angle case. Class 2, dip 2, dip over by over 100%. We suggest the removal of the wisdom teeth. And he got posterior crossbite, anterior deep bite. So upper posterior tests were used to retract the upper dentition, trying to correct the class 2. But we need to open the deep bite first. So we install anterior tests on both arches. So after the bite was opened, we distalize with the test to retract the canine and incisors to correct the class 2. However, the relationship looks still a little bit class 2. However, if the test fail, what would you do for this kind of difficult case? I asked the patient to wear class 2 elastics. However, because we need patient compliance for elastic wearing, so I prefer using tests instead of class 2 elastics. So I inserted plateau tests in conjunction with the modified plateau test. Although we try for 1 year for upper arch, total arch desization, but still, there was still canine class 2 on the right side. So finally, I decided to insert another buccal shelf test, but I slanted the buccal shelf test forward so that I can attach power chain from the terminal molar to the buccal test. And then you can see I can protract the lower dentition forward so that I can get my buccal interdigitation to solid class 1. Here is the treatment comparison. What I'm trying to explain is there must be boundaries for tooth movement. There must be boundaries. We do not know where the boundary is, but we just try total arch desization first. But what would you do if you cannot distalize the upper arch anymore? I decided to protract the lower to match with the upper. Here is the OPG, look good. And the cephalometric superposition showed upper arch desization. And I can protract the lower anteriors to match the upper dentition. So maybe you need a plan B for every case. If the treatment strategy does not work well, we can continue the treatment. The next 2013 AO meeting in Philadelphia, I shipped to class 3 treatment with TAS. I tried to apply total arch desization in class 3 treatments. I think for class 3 treatment, extraction or non-extraction, that's a problem. especially for class 3 cases. Why is that? Usually, we prefer to retract the lower for class 3 correction. But the reality sucks. It tends to advance the upper dentition to become a protrusive facial profile after anterior crossbite correction. So like this case, a class 3 moderate protrusion, not very severe, but the lower dentition, there was no crowding at all. So I tried to use self-ligating bracket to align the very severe crowded upper arch. The treatment proceeded very well, so we can correct the anterior crossbite in 4 months. Then class 3 elastic correct the class 3 malocclusion very fast in 8 months. So here is the comparison before and 8 months. We can see the occlusion-wise, it looks good, but the facial profile became a little bit protrusive. At last, the patient decided to remove full bicuspid so that she can get a better facial profile in the end. Here is pretreatment, non-extraction, and here is the result of extraction. But a similar case, you can see not much crowding in the lower arch, but severe crowding in the upper. I decided to remove the lower wisdom teeth, then expand the upper arch and retract the lower dentition with tests. You can see the anterior crossbite was corrected successfully. However, when I correct the anterior crossbite, the facial profile became protrusive like this. Of course, we can extract 4 premolars, but this time I chose to add 2 upper posterior mini screws to retract the upper arch. And with the lower test, we can distalize both arches at the same time to achieve the facial harmony in the end. If we compare the cephalometric superposition, you can see when we correct the anterior crossbite, most of the tooth movement was achieved by upper anterior flaring. And after I install the upper posterior test, I can continue to distalize the lower dentition, and at the same time, I can distalize the upper dentition so that I can get the ideal facial profile after I finish this case. And here is the cephalometric superposition. You can see the black initial, the purple after anterior crossbite correction, and in the end, the red indicates we retract the incisor back to restore the original position, but the net effect is lower dentition distalization to correct the anterior crossbite. So with the test to distalize the lower dentition and also upper dentition, we can maintain the facial profile and improve the facial profile after the anterior crossbite correction, which leads to temporary protrusion. However, of course, the diagnosis is the most important one. You can see a very similar case. Not much crowding in the lower, only a little bit on the upper. So I decided to remove the wisdom tooth on the upper and retract the lower dentition with tests. After anterior crossbite was corrected, we continue to retract the upper with the upper posterior test. Although the occlusion looks good, but the patient complained of steel protrusion. this was not what he wants. So we decided to remove 4 premolars and close all the spaces to improve his facial profile. So let's compare pretreatment, non-extraction, and extraction. I think the patient was right. I like the profile better. So for any treatment strategy, you need to be very careful of the indication, diagnosis. So extraction and non-extraction, I think is just like the pendulum, swing back and forth. You need to be very careful, and you need to communicate with the patient to see what he or she wants. I'd like to share you another dilemma case. Because this lady asked for retreatment because she got her orthodontic treatment during her adolescence. You can see the lower first premolar were extracted in her prior treatment, but she complained of protrusion. I think that is because the late mandibular growth after orthodontic treatment. So I decided to remove the lower first molar to close the space. Then we will retract the lower dentition. What about upper? In class 3 cases, I hesitate to extract in the upper arch. So I just try to digitalize the whole upper arch with tests. So here we will go. You can see I remove the lower first molar and retract the lower dentition. Retract the lower anterior to close the space, but I need the upper posterior test to digitalize the whole upper arch to keep ideal overjet. When we close most of the spaces in the lower arch, one day I noticed the root looked so obvious through the lingual mucosa. So I decided to stop the lower retraction and close the spaces by protracting the lower molars using the test. I use subapical test with the extension lecture wire to hook the terminal molar and forward, and also use class 2 elastics. So I finished this case like this. Looks like the lower second molar replaced the first molar. All the others look basically the same, but the better interdigitation, of course. And we can see the lower incisors became more upright, retracted, so she got better, less protrusive facial profile. The OPG looked not bad. And here is the cephalometric superposition showed a large amount of lower incisor retraction. For the upper, we can use the upper posterior test to distalize the whole upper dentition so that we can keep the ideal overjets after we close lower first molar spaces. But we had better be careful about the periodontium. You can see the lower incisor, the root of the lower incisor seems a little bit out of the alveolar trial, which is very dangerous. You cannot retract it all the way. Maybe you need to be careful monitoring the alveolar housing. If the root were still within the alveolar housing. If not, we had better stop and change the direction of tooth movement. Not all the spaces were closed by retraction. So that was for my 2013 AO presentation about Class 3. The next is WIOC. In the same 2013, we got a large group of delegates to promote the first Taiwan International Orthodontic Forum in 2014. My topic is top case made easy with tests. And I shift to my focus on protrusion cases. That is, some cases might be so difficult beyond maximal anchorage because so severe protrusion. You can see quite severe protrusion, and we plan to remove 4 bicuspids, of course, but unfortunately, she got hopeless lower left second molar, and for the lower right, I think the first molar is poor. So I decided to remove these 2 molars in addition to 4 premolars. And also I plan to remove the upper wisdom teeth. But after extraction, when we bonded all the appliances, you may notice so much space in the lower arch. So we can imagine the overjet would be increased a lot when we close all the spaces because the anchorage. So we need to reinforce the anchorage in the upper arch. Using the upper posterior test, we can distalize the whole upper dentition to catch up with the lower incisors to keep ideal overjet when we close all the spaces. And we can improve the facial profile like this. Actually, before I use tests, I cannot imagine this kind of treatment result. If we look at the cephalometric superposition, we can see a large amount of incisor retraction. There was no anchorage loss at all. And after complete space closure, we can distalize the whole upper dentition. And we can close all the, I think the spaces we close in the lower dentition per site is more than 20 millimeters. So that is really amazing to me. Another protrusion case, we can see a lot of prosthesis, including a cantilever prosthesis with the upper left lateral incisor missing. Besides that, we may notice here a hopeless upper right first molar. So 4 premolar extraction plus wisdom teeth removal and this hopeless molar. So with the ascetic pontic hung on the arch wall, we got each premolar, 1 premolar space on each side and 1 extra first molar space on the upper right. You know, during the space closure, there would be a tendency for the upper dental midline to move to the right because on the upper right, there was an extra molar space there. But with the upper posterior test, we are able to maintain the dental midline pretty well when we close most of the spaces. That's the beauty of the test. However, the profile improvement at this time was not good enough. Although there was still some spaces over the upper right. When we tried to retract with upper posterior test, you may notice here, there was no overjet, insufficient overjet for upper arch desization. So I decided to put another 2 buccal shape tests to disize the whole lower dentition so that I can get the overjet for upper arch continue to disize. At the same time, I may need anterior tests for anti-bowing because when we try to disize a lot, the bowing effect would be larger. So we need anterior tests for anti-bowing. After a massive amount of incisor intrusion and retraction, you may see the upper incisor became so short. It looks embedded into the gingiva. And here, because we retract so much, but the bone stay, it looks like exoastosis. So we arrange a periodontal surgery, a crown lengthening to restore the crown length, and alveoloplasty to smooth the alveolar contour. And here is the how she look like at debonding. Here we can close all the spaces and restore the missing lateral with implant prosthesis. Cephalometric superposition showed a large amount of incisor retraction. And we can also notice the counterclockwise rotation of mandible to improve the chin projection. Here is the progressive facial profile change. This was the debonding. And 9 months after debonding, during follow-up, we may notice the soft tissue profile looked even better. I think that is because neuromuscular adaptation after we correct the hard tissue and the soft tissue adapt. So I think this case is a very good example to illustrate the beauty of interdisciplinary treatment. However, again, I'd like to share you another failure case. Although it looks like very similar situation, but only one missing. I mean, if you miss any details that is critical, maybe it will lead a failure. Regular protrusion, a large decay at the upper left with endodontic involvement. Of course, full bite extraction, and I would suggest full wisdom teeth removal. However, this lady asked me to extract the upper left first molar instead. After extraction, you may notice this is the start. We start the start of space closure. 3 months later, here is the archwall. Look quite strange, right? Not so straight. It is because there is some bowing. There is some bowing during our space closure. It is because the elongated wisdom tooth, which impede by the lower second molar. I cannot close the upper space because I cannot move the elongated terminal molar forward. There is some occlusal interference between the wisdom tooth and the lower second molar. That's a big problem. So in addition to this buccal test, I inserted another plateau test here, but also bound a segment to accept the intrusive here. But I need to install another mean screw distal to terminal molar, because this is a cantilever. The distal end is not so easy to be intruded. If I do not have a mean screw distal to the terminal molar, it will be difficult to exert the intrusive force. So finally, after this setup, you can see the molar started to be intruded, embedded into the gingiva. The wire look straight. Then I can start the space closure. But during the space closure, you can see all the other quadrants. The spaces were all closed. Only the upper left, still a premolar size space. And we can see some transverse bowing here. The buccal overjet was decreased to posterior crossbite. So I need the patient to wear the posterior crisscross elastics, trying to get rid of the posterior crossbite. Although the spaces were closed, but you may see the time was a long duration, more than 3 years. The patient started to complain of long treatment time. And of course, the dental midline tend to shift to the left. And I also need the patient to wear asymmetric interarch elastics. Finally, we can close all the spaces. The midline was maintained well. However, the buccal segment, you can see the buccal segment was still a little bit class 3. So I bound the button here and used the buccal test and the palatal test to protract the upper posterior quadrant, the upper left quadrant forward. And finally, I can finish this case at this time. That is over 5 years, Here, OPG looked fine. But this is not what I want. I want to make the tough case treated easy, not make the good case gone bad. So the diagnosis and treatment plan, I think it is the most critical point. What did I do wrong? I think molar intrusion should be easy with the help of tests. However, you need to know if the terminal molar is not so easy to be intruded. I hope you will learn my lesson without trying by yourself. So my next 2014, it was 6th WIOC in Anaheim, in the United States. I spoke on interdisciplinary treatment with tests for mutilated dentitions. Here we have a mutilated class 3 malocclusion, anterior crossbite. And you can see 1, 4, 4, 6 were missing. 2, 5 residual roots. And these 3 were hopeless. So I decided to remove 3, 4, this one, to correct and correct the anterior crossbite. I decided to extract this one and this one to correct anterior crossbite. In addition, I plan to remove the wisdom teeth of these 3, except this one, because I try to maintain 2 molars in each quadrant, 2 molars in each quadrant. So the treatment plan was like this: close 1 premolar space at each quadrant and correct anterior crossbite. The space left in the end would be restored with implant prosthesis of these 3. Because the treatment plan involved a premolar extraction here, so I tried the premolar auto transplantation to replace 1 dental implant. So here is the initial setup. I used the posterior test to digitalize the lower dentition. Here is the bitable when I bonded the upper dentition because I try to avoid the bracket interference. So this is the time for auto transplantation at the 5th month. So before I extract the donor, I drill a hole. I raise the flap and drill a hole here, and I extract the premolar and try it in. Then we suture the flap with the wire and bracket to stabilize the auto transplant here, and use the periodontal dressing. Within 2 weeks after surgery, we arranged the root canal treatment to avoid the endotoxin released from necrotic pulp. So after that, here is the auto transplant. After that, we insert the open coil spring here to create the space for the upper left lateral incisor, and keep the space closure, keep retracting the lower anterior to correct the anterior crossbite. So here we correct the anterior crossbite. After we create the space, we can hand the aesthetic puncture here. And here is the last space left, so that this space is for dental implant installation. So the other specialists started the guided bone regeneration, implant installation, and the connect tissue grafts step by step. And finally, we can finish this case like this. One auto transplantation and 2 dental implant. Here is the cephalometric superposition. We can digitalize the lower incisors to correct the lower lip protrusion, and finish this 4 months rehabilitation by 1 auto transplant and 2 dental implants. And here is the follow-up, 3 years, 8 months. And here is the periapical film of this one, the auto transplant. So for this kind of 4 months rehabilitation, if we can include the interdisciplinary treatment, we can have this kind of auto transplantation to preserve the patient's extraction tools to continue the use. But not every case is as successful as the previous one. I'd like to share you again a fatal case. Here we can see a protrusive case with the gummy smile. And in addition to lower right first molar, the lower left were two missing. One missing was the second premolar and the first molar. So the treatment plan is upper bicuspid extraction, upper first bicuspid extraction, and upper wisdom teeth removal. Close one space in the lower arch at each quadrant, then one dental implant. But with the concept of auto-transplantation, we can transplant one premolar to the place of the dental implant. So here we go. We can see after initial alignment, then we can we do the auto transplant here. However, this one was not successful because of gummy smile. I insert anterior test, upper anterior test for gummy smile correction. And I started the space closure in the lower arch. However, you may see the angulation of the second premolar look not so good. So I cannot use the regular sliding mechanics that I use to close the spaces because there was some friction. So I use the closing loop to close the spaces and finish this case like this. Actually, this patient was happy because of the profile improvement and the gummy smile correction. If we look at the supplementary superposition, it looks good. And here is the OPG. But if you look at the angulation of the auto transplant, you may notice the angulation seems not so good. It is because I got the ankylosis. The reason why I failed in this case, I think there might be some reason. The first one might be the alveolar ridge actually not wide enough to accommodate the roots, to accommodate this root. And the flap adaptation is not good enough. And then the wire was not passive. So the bonding position of the bracket and the wire, the combination of the wire and the bracket relationship was not good, was not so passive. So that I got this case to be ankylosis. And one thing which is more important, at least, I chose the right site for the auto transplant because once it was ankylosed, I cannot move it at all. But luckily, we can finish the occlusion like this. Although it was ankylosed, we cannot move these tooth, but we can finish all the other teeth in compatible position with this ankylosed tooth. But we need to know the prognosis of the ankylosis. It due to resorption, the replacement resorption. So I had better to watch it very carefully to follow up this case. The periodontal pocket looks good. After more than 6 years, still looks good, but the periodontal membrane looks not so clear. There might be some resorption. So I learned my lesson, and in this case, a multiple missing in the lower arch, but the severe crowding in the upper. So I decided to do the auto transplant from here to here, from here to here. So this is the first one. The upper to the upper right to lower right, the upper left to the lower left. But please notice this one. I rotate this premolar to mimic canine, and more importantly, I rotate the transplant to be accommodate in this narrow ridge, because the ridge is not so wide. So we had better rotate a bit. And after the auto transplantation, we can close all the spaces and finish this case like this. Facial profile, no problem. Occlusion, basically okay, although not perfect. But patient was happy. And we can see the OBG looks good. And here is 10 months follow-up. Here is the periapical film at follow-up. We can see the periodontal membrane clearly, lamina dura very well. So after the WIOC in Anaheim, because that was in United States, so Dr. Greg Huang and Dr. David Turpin, they were among the audience. So I got the invitation for the next AAO meeting in San Francisco in 2015. So I spoke on tough case made easy with tests and interdisciplinary treatments. This time I tried to focus on some borderline case treated non-surgically. The first one is a very protrusive case with gummy smile, but very upright upper incisors, which makes the upper incisor retraction very difficult. But with the test, the combined intrusion and retraction force system, I retract the upper dentition and intrude the upper incisors to correct the gummy smile, along with the torquing spring. We can control the upper incisor torque. So this is the anchorage setup. The combined intrusion and retraction force system. We can close all the spaces. Here we can see the exoastosis. We need the periodontist to help us to remove the exoastosis and smooth the alveolar bone, and also restore the appropriate crown length so that we can improve her facial profile and also correct the gummy smile. And here is the cephalometric superposition. You can see there was no anchorage loss at all, and we can have the incisor intrusion and retraction. And this was traced by Dr. Ronsi. I'd like to take this opportunity to thank him again. But the next case, I'd like to share with you, although the basic combined intrusion and retraction force system works very well to reduce the protrusion. But sometimes you may feel that you want to distalize more. Like this case, because of the thick lip, you may expect the the profile response might not be as good as regular case. So 4-bite extraction, combined intrusion and retraction force system as regular. When we close most of the spaces, although there was significant profile improvements, but still you want more. The patient was not wants more retraction. So I decided to install 2 buccal shelf tests to maximize the lower retraction so that I can keep retracting the upper dentition. And here is the progress. Well, here is the final results we can achieve. A better profile improvement in comparison with the, when we close all the spaces, there was still some protrusion. But if we can install the lower test, then we can design lower arch so we can get enough overjet for upper dentition to retract more. And here is the cephalometric superposition. Combine intrusion and retraction force system on both arches to maximize the profile improvement. Okay, maybe I bypass this part. I just want to emphasize, if you can use the combined intrusion and retraction force system on both arches like this, then you can continue to improve the facial profile from here to here. And the key point is buccal shelf test. Buccal shelf test. And another point would be incisor torque control. Because when you distalize a lot, if you cannot control the incisor torque well, there would be a big problem. But again, I arranged the next case to be a fatal case. Because this case, you can see she was so severe protrusion. Even 4 bicuspid have been extracted. But the patient asked for retreatment after her first orthodontic treatment with 4 bicuspid extracted. Actually, I was excited to see the low first molar. The condition were not good. So I proposed to remove these 2 low first molar and upper wisdom teeth, because I think I can retract the lower incisor with the molar space, and I can use the upper posterior test to distalize the whole upper dentition. So here is the progress. Although I can distalize the upper arch during the space closure, but the overjet, still, I cannot get ideal overjet because we know there are boundaries for tooth movement. There are limitations. So in the end, I need to install the buccal test and protract the low molars to finish like this. Occlusion-wise, it was good. The facial profile improved significantly, but the things did not proceed as my expectation. The OPG looked fine. The cephalometric superimposition showed a large amount of upper dentition digitalization, but I cannot retract it all the way. I need to protract the low molars with the buccal shaft test to protract the low molars to finish this case. And here you can see the progress, the progressive facial profile change. This is pre-treatment, 2 years, 4 years, and almost 5 years. You can see the facial profile changes. Actually, patient was happy, but I think the experience actually quite horrible because you do not know whether you can achieve your treatment goal or not. You need to have a plan B when you try this kind of extreme case. Extreme sports is usually quite dangerous. You need well prepared yourself for this kind of trial. But when I come across this case, I changed my treatment plan. Again, he is a retreatment case. You can see the upper first premolars have been extracted, lower non-extraction. But he complained of protrusion and retruded chin. So we decided to remove lower first premolars, low first premolars. But this time I chose upper second molar because I think if I have a spaces, if I have a second molar space, then I can digitalize the 6 to 6 uneventfully because I got a space there and I can have tests for maximal retraction. But actually, I added the lower buccal test for maximal retraction because you can see the overjet was minimal. If I cannot retract the low more, then I cannot retract the upper. So this is the force system in this case. Combine intrusion and retraction force system on both arches to maximize the retraction. 15 months into treatment. Here is the profile change. Not too bad, but we can continue the force system to achieve this kind of profile improvement. The cephalometric superposition showed a massive amount incisor intrusion and retraction. And because of the occlusal plane of the upper arch was moved upward so that we can get counterclockwise rotation of mandible to rotate the pogonium forward to improve the chin projection. Here you can see the space closed at 15 months, and in the end, here it looked different. It was because total arch digitalization continued, and counterclockwise rotation of mandible improved the chin projection. So the next is another journey to Angle Society. It was Dr. Greg Huang who invited me to join the Angle Society. He told me that a good friend, Dr. Tae Kim, was also a member there. And what I need to do is to bring 3 completed cases and treat 5 cases prospectively. So 2016, I went to Portland for angle meeting. For my first angle meeting there, and enjoy the conference very well. So I decided to treat 5 cases prospectively. And here is my case number 1. I chose this case because actually this was not very difficult case, canine impaction on the palatal side. So the patient asked me to reposition this canine back to its original position. So I exposed this canine and I retract this canine with the palatal test. And here is the comment from the admission committee. And the comment is, I do not think there is a big risk with the root damage to the maxillary left lateral incisor. If it is posed vertically into the palate first before being moved labially, it will end up in good position. So after I retracted it, expose a little more, then I start to protract it to the buccal. But at this time, I check a CBCT to find there was barely, almost no bone on the actually labial side of the canine, the labial side of the canine. So what should I do? During the progress of my angle case, I went to India, Goa, for 8th WIOC in 2016, and I spoke on transposition. And here is a canine transposition case, bilateral canine transposition. So when I try to correct the transposition, I retract this lateral incisor first so that I can give way for the canine to distalize. So I utilize the palatal test for palatal movement of the lateral incisor. And the next step, I need to move the lateral incisor to mesially. So I use the power chain to move the lateral incisor. However, if you look at the CBCT here, you may find here the root was still transposed with the lateral incisor. I mean, the root of the upper right canine was still transposed with the upper right lateral incisor. Although we look, it looked fine clinically, but actually underneath the root was in close contact. We need to move the root to move away from the root of the lateral incisor. So I decided to bond the lever arm to mimic the root of the canine and move the root first, then I can correct the transposition. Not until the roots were clear of contact, close contact. And finally, you can see after I confirm the root clearance with the CBCT, then I can move the canine back to its ideal position. But still, if you look at the CBCT, you can see the root, the direction of the root was almost horizontal, which require a long term to move the root upright on the on its original angulation and position. So it took 5 years to correct the transposition. In this case, you can see before and after. Here is before and after. OPG looked fine, and both the canine transposition were corrected. And here So if you ask me the key point for the final success, I will say one of them is the lever arm to pass the force through the center, near the center of resistance. And another key is CBCT. I think that is the light at the end of the tunnel. Otherwise, you do not know the condition, the relationship between the roots underneath. And every time a good friend of mine, Dr. Chris Chan, he always say, believe me, it's easy. But actually, I need to say, believe me, it's easy to end up failure, because I'm going to share you another failure case. You can see the extracted canine, a severe root resorption like this, and that is because root collision. Again, you can see a canine here. After exposure, start to track the canine. It looked not bad. Here, we start to rotate the canine from here to here. Initially, we bound the lateral, but somehow we feel that it would be better to have freedom for this lateral incisor when we move this canine. If there is some root contact, there is still some freedom. So we release this canine, this lateral incisor. But when we try to rotate this canine, something happened. You can see severe gingival recession like this. So I was frightened, and I decided to stop and try to move it back to intrude this into the soft tissue gingival and try again. But at this time, I took a CBCT, and I noticed here the root, the relationship of these two roots are still in close proximity. And if we look at the panel, there was still a cross. So finally, I lost this canine. When I removed the canine, it looks like this, a severe root resorption, a result of root collision. So what would you do for the next? Finally, after a struggle, a couple of months, I decided to use a plateau test with a spring to hold the incisors and protract the buccal segment forward to close the space, and finish this case like this. Right side class 1 and left side class 2. So what would you do for my angle case 1? My angle case 1. I decided to do the auto transplant. I decided to try the auto transplant before it was too late. Because I think if I wait, maybe after the gingiva was started to recede, it might be too late. So I decided to try auto transplantation before it was too late. And I finished this case like this. It looked not too bad. All, of course, except the canine, all the others look so simple. But that was patient's chief complaint. So I decided to try the auto transplantation, and it works well. And I finished my auto transplantation in this case, so that I do not lose this canine. And here is the comment from the admission committee. Without CBCT, most of us would have continued to move the canine into the arch and finished without realizing and had a loss of the canine. So I think it's quite important to read the CBCT in this difficult case. Okay, so here is a case transferred by a colleague because of ankylosis of the canine. Here is a radiograph, and clinically, I rebound the bracket and try to make space for the canine and try to use tests to extrude the canine, but in vain. I think it might be ankylosis, but I still want to try to retract this canine with a test. But finally, I raise a flap, then subluxate this canine and start elastic traction. And finally, I see some tooth movement of this canine. And I think it's possible for us to move this canine. Of course, all the rest, everyone can see how it is going, just regular orthodontics. So the key for this ankylosis, I'm not sure whether it is ankylosis or not, but create space, open a flap, try to tract and open a flap, try to subluxate, then move it, and that is the key to success. But not every case was so lucky. What if you come across a real ankylosis? This is a regular protrusion case. So 4-bite extraction and wisdom teeth removal, then space closure with maximal anchorage with test. But one thing happened. We noticed the overjet was become larger and larger because we retract the lower, but we cannot retract the upper. And the arch form became weird. So I changed to the closing loop, but still I cannot close the space, although the space became smaller, but we can notice the anchorage loss of the upper posterior teeth. So we can confirm there was an ankylosis in the front. After trying to know which one is the ankylosed incisor, then we decided to bypass the incisor and retract all the buccal segment back to the ideal class 1 occlusion. Then we open a flap, cut a single tooth osteotomy, and move this segment back to its ideal position, and using bracket and wire to stabilize this segment and finish this case like this. Single tooth osteotomy is the key. Of course, before that, you need to diagnose this, which one is ankylosis. And you need the test to digitalize the buccal segment to its ideal class 1 relationship. And at last, single tooth osteotomy to reposition this ankylosed incisor. Okay, the next is WIOC in Kobe, Japan. And 2018 AAO in Washington, DC. I spoke on orthodontic correction of adult gummy smile with tests and periodontal surgery. And here we can see some gummy smile correction successfully. but I like to show you the most difficult one because she was definitely a surgical case. And she refused to receive orthodontic surgery. So with the understanding of compromised treatment results, we removed 4 bicuspid and wisdom tooth, then combine intrusion and retraction force system on both arches. Here you can see again, the arch wire at the terminal did not move upward. So I decided to install another test, distal to terminal molar, and also a plateau test on each side to focus on molar intrusion to close this open bite, So with the molar intruded, we can close the bite gradually and finish this occlusion. And here is the treatment results. But if you may notice here, after a massive amount of retraction, there was so robust alveolar bone. We need a periodontal surgery. OPG looked good, and the cephalometric superposition showed a large amount of incisor intrusion and retraction. And if you look at the cephalogram superposition, intrusion everywhere, so that we can get the counterclockwise rotation to improve the chin projection. Low facial height was reduced, mandibular angle was closed, and the Pogonian was moved upward and forward to improve the chin projection. So here is the mandibular angle reduction from 49 to 45. Here are some numbers. For this kind of extreme case, actually, the treatment goal is to reduce the hard tissue volume anterior, posteriorly, and also vertically. If we close all the spaces, it looks like this. But if we can further control the vertical, it will improve a little bit more to relieve the tension. You can see the chin projection improve progressively. And here is the before, after follow-up, and 3 years follow-up. But some case, on the contrary, for this low angle case, although the incision show not bad, she complained of protrusion. So we just use combined intrusion and retraction force system as usual to close all the spaces to improve the facial profile, but the patient started to complain insufficient tooth show, although she was satisfied with the profile improvement. That is 10th WIOC in Bali. I learned something from some other masters. The upper incisor extrusion and the lower incisor intrusion for cases with insufficient tooth show. So here I try this anterior test extrusion and lower incisor intrusion for this case to finish this patient like this, and she was happy for the regain of the incisor tooth show. And here is the progress. The start, she complained insufficient tooth show, and then we apply the anterior test extrusion and finish. And here is some setup of this technique. And that is the beauty of the international conference experience, that I can learn a lot from some other colleagues So that it inspired me in my cases. I shared this in my 2019 TAO annual meeting with the anterior test extrusion. Here we can see even more lower angle cases like this. I start, for sure, you will not want to extract in this kind of low angle case. So I use upper posterior test to digitalize the upper arch, trying to correct the class 2. And I also, because I cannot digitalize all the way, so I use slanted buccal test to protract the lower dentition. And after that, I start the anterior test extrusion to improve her incisor show. It seems a little bit improvement, but I want to try it again and finish this case like this. The improvement looked significant because of anterior test. We can extrude the upper incisors so that she look even better. The next was 2019 AAO in Los Angeles, and the next 11th WILC in Bucharest, Romania. I spoke on application tests in ortho implant combined cases. Here is an example I'd like to share with you. For this protrusion case, for sure we will extract 2 upper bicuspid. And for the missing in the lower dentition, we may need use the combined intrusion and retraction force system on both arches to arrange the space like this. And in the end, we will need 2 dental implants on each side to restore the missing. So the force system would be distal force to retract the upper dentition. As the line of action is way below the center of resistance, the anterior tend to dump anteriorly. The anterior tend to dump. So we need an upper anterior test to anti-bowing. And at the same time, we will generate counterclockwise moment to maintain the incisor torque. Besides that, the torquing spring was also used to apply the plateau root torque to control the upper incisor torque. To level the curve of speed, we use lower anterior test. And to upright the low molars, a segment of open coil spring was inserted in front of the molar. So the force will above the center of resistance and tip the molar back. And the reciprocal force will tend to flare the lower incisor labially. So we use the lower posterior test to distalize the lower anterior and prevent the lower incisors from flaring. At the same time, you may see the dental midline was off. The right side was class 2. So I asked the patient to wear the asymmetric interarch elastics for midline correction. And it's time to install the dental implant. So I talked to the implantologist to install the fixture 1 millimeter off to the regular position, 1 millimeter distal on the lower left, and 1 millimeter mesial at lower right, according to the planned tooth movement, because we try to correct the dental midline by pushing the lower anterior to the left. So here I got, after the implant installation, And afterwards, after a couple of months for osteointegration, the prostheses were fabricated as soon as possible. And I was soon informed, I was asked to intrude the upper molars because there were insufficient interocclusal space for the implant prosthesis. So I installed the plateau test to intrude the upper molars and insert a segment of open coil spring here to push the right buccal segment to the left side to correct the dental midline. So, so after a couple of months, the dental midline were coincident, and the occlusion of the right buccal segment improved quite a bit, and we can finish like this. The facial profile were improved, and the interdentation looked good. And here is the before and after. Before and after. And this was a good example using the dental implant as anchorage to fine-tune the final occlusion. And here is the cephalometric superposition to show you the profile change, the amount of incisor retraction. And afterwards, we need alveoloplasty to remove the exoastosis and also restore the crown length, appropriate crown length. And here is the final results. So talk to your implantologist and communicate with them for the ideal position of the dental implants. And finally, I'd like to share with you my final case, interdisciplinary treatment for mutilated dentition with mini implants, dental implants, and auto transplants. This lady, asymmetry, severe protrusion, occlusal plane canting. And you can see, in addition to gummy smile, the gingival line was also canted and multiple missing in the lower arch. That's why she was a mutilated dentition. In consideration of her facial profile and skeletal disharmony, actually the treatment plan, the ideal treatment plan would be 1 premolar extraction space in each quadrant, then close all the spaces and orthodontic surgery to correct the skeletal discrepancy. Then dental implant to restore the missing. However, the patient declined the surgical approach, and she also asked for minimizing the number of dental implants. So finally, we decided to close one space at each quadrant, close one space at each quadrant. Then the space left was also restored by auto transplant here and here. So in the end, there would be one dental implant only, one dental implant only. So this patient was happy with this treatment plan, with 1 dental implant, 2 auto transplant. So here we go with the upper posterior test to start the retraction of upper arch, and anterior test for bite opening, and in conjunction with the upper right posterior test, the occlusal plane was correct. The occlusal plane was correct as possible. Here we have the first auto transplant from the upper right second premolar to the upper left second premolar, and here is the second auto transplant we are going to receive from the lower left wisdom tooth to the lower right first molar. So here we have the second auto transplant, the first, the second. So we keep the space closure, and here is the last space for the dental implant. So after implant installation, provisional fabrication, and here is how she looked like at debonding. Although it looked a little bit strange with 3 premolar at lower left, but the overall occlusion looked not bad. And here is the final treatment results. The occlusion-wise, it was good, and for the profile change, she was very satisfied with the profile and the aesthetics. You can see the gummy smile was corrected, although the asymmetry remained, but she, because we hide the gingival line above, so it was not obvious for the occlusal plane canting. So we solved this 4-month rehabilitation with 2 auto transplant and 1 dental implant. And here is the follow-up of these 2 auto transplant. It looks not bad. And the cyclometric superposition, we can see a large amount of incisor intrusion and retraction. And because of the intrusion, we can solve the gummy smile. And we also move the occlusal plane upward so that we can get the counterclockwise rotation of the mandible to improve the chin projection. Here to here, you can see the improvement of on the aesthetics. And here is the 7-year, 8 months follow-up. Still look very good, and the auto transplant also look stable. So after the WIOC last year, 2019 in Bucharest, Romania, and annual meeting last year in Portland, everything was locked down after the COVID-19 pandemic. So after a couple of months, I was invited by Orthodontic Mastery Group on Facebook, and also IOS, Indian Orthodontic Society. The first 2020 in-person conference was TAO annual conference in December, the first in-person conference. But I prepared the talk today. I mean, I prepared the content I took today, but actually I cannot finish the content in my time slot. So I'm very happy to have this opportunity to share with the colleagues today with the orthodontic turning point from failure to success. It is my pleasure to share some of my thoughts with you. You can, like this, non-extraction in low angle case, but what would you do if you cannot achieve the total arch desization in the upper arch only, or non-extraction treatment with tests in class 3 cases and the bimacular protrusion case? But what if the large space, very difficult to close? I share with you the difficulty I come across. So everything might be a best solution, but I like you to save your time in try and error. If there is someone who has done the same error. So here is my presentation today. I hope you will enjoy my talk. And if you have any question about these materials, I will leave my email there. You are more than welcome to communicate with me. At last, I like to thank all my colleagues because one is too small a number to achieve greatness. And we have so many orthodontists working together in my office. Besides the orthodontists, we also have some other general practitioners, prosthodontists, periodontists working together as a team. I also like to thank all my family, my beloved wife and 3 daughters. And especially I like to thank my better half flying together with me to be so supportive wife and give me free wings to fly. Thank you for your kind attention. Here is my email, and I hope everyone enjoy, and please ask any question if you have some any questions.
Wow, are you finished?
Yes. Yes.
Yeah, wow. Amazing webinar. Today, more than 200 dentists from all over the world have attended the webinar to learn from you. And I was really impressed by your super challenging cases. I think you have broadened the scope of orthodontic treatment for our members today. You said, believe me, it's easy, really cool. You sure a professional, I think. You sure a professional. Thank you for your effort. And now we have a time for question and answer. I believe the panels have really, my panels have questions in regard to the lecture. Meanwhile, I'll try to get some questions from the chat box. Okay.
Thank you for great lecture, Doctor. It was very impressive and amazing cases. I have one question. For upper and lower arch distalization, which area is the best site for miniscrew insertion? In your case, you usually insert miniscrew between first molar and second molar. Is there any special reason?
Okay. Usually in my opinion, I think infrazygomatic crest is a good position to insert the miniscrew because there was abundant bone volume. And I think the most critical part would be outside the roots, because you can see many of my cases, they do not only, they not only maximal anchorage, but also distalize the whole dentition after complete space closure. So if you position the miniscrew in between the dental roots, there would be impede further distalization of the whole dentition. So I try to insert my miniscrew outside the roots and also the buccal shelf. Yeah. If you observe the angulation of the miniscrew, it's usually parallel with the roots, or at least oblique. Usually my insertion angle of the so-called IZC screw is about 60 degrees to the occlusal plane. 60 degrees to the occlusal plane. It gives me a best shot for the outside the roots.
Okay, I agree with you. Yeah.
But actually, I need to say it depends on the anatomy. If the patient's anatomy does not allow, sometimes I will shift to the plateau side, because palate, there was no vital structure there, and there would be no chance for the miniscrew to interfere with the tooth movement. But you know there are pros and cons. The downside for the plateau mini screw is you need something, you need some lab. Of course, it is good. I think that is very good for the full system. But clinically, it's more convenient for us to use buccal. So actually, I will try buccal first. Then if the patient, if the condition is not so good, the test failed, then I may consider to shift the mini screw to the plateau side, but with extra lab.
Okay, thank you. Yeah.
Thank you for the question.
Thank you for the great lecture, Doctor. I'm Lee-Hyung Kim. I was deeply impressed to see your wonderful cases. The difficulty of all cases were really high and very complex, and all were resolved very well. Thank you so much for a really great lecture. I have a question. When the screw is installed, the vertical vector acts as an intrusion force. So the display of anterior incisor would normally decrease, or vertical problem may worsen in hypodivergent facial pattern cases. What is a good alternative for patient with a severe protrusion with a lack of maxillary anterior display?
You mean
I mean,
hyperdivergent case?
yeah, hypodivergent and severe protrusion cases. If I install the mini screw in the posterior region, normally the vertical vector would intrude the anterior incisor to reduce the display of anterior incisor. So in those cases, what would be the best treatment options?
You mean if the patient does not have a gummy smile?
Yes, right.
Okay, that means vertical maxillary excess or not vertical maxillary excess. That means you need to intrude the. Actually, we can think this way. Severe protrusion. So extraction, then maximal retraction, then vertical control, but not mainly in the front, but mainly in the back. You need to intrude in the back. Now, then still, we need some counterclockwise rotation of mandible.
Yeah.
I'm not sure. Did I answer your question? What alternative you expect?
Actually, in those cases, I usually install the mini screw in the posterior region and hold the second premolar by ligating the by making indirect anchorages using the TES. But it might work in the moderate cases, but in severe cases, sometimes I need to distalize molar. So I wonder what would be the, for example, by changing the height of the lever arm, could I control the vertical vector? I mean.
Okay. Okay. What you mentioned is a very difficult situation, I think. But my basic thinking is just like just what I said, just extraction to reduce the protrusion and maximal retraction for profile reduction, and also posterior vertical control. Usually I do not use I do not use I do not use lever arm for the force system. I use combined force system because I think it's more easy for me to control the force system by apply intrusive force or apply retraction force. Of course, we know the combination. We know the combination. We can expect what the force system we like. We can emphasize the posterior intrusion, or we can emphasize the anterior intrusion. You know, have you seen the promotion video I sent to the WEBCEPH? You do not know.
Promotion.
Oh, it's okay. I believe you maybe you do not see the video, but I can show you the anterior torque. I see. I try to find retreat. Is it okay? I show you this case to answer your question.
Of course.
So
Can you share,
maybe
yeah.
here we have this case, no dumisma, severe protrusion, actually a transfer case. You can see upper single arch extraction. After retraction, the anterior crossbite occurred because of lingual tipping, uncontrolled tipping. And we can see the CBCT outside, out of the alveolar process. So we remove the braces and rebound with lower second premolar extraction, lower second premolar extraction. And I control anterior with the anterior test. So combine intrusion and retraction force system to retract both upper and lower, and also control the torque, incisor torque. So you can see the regain of the torque. And here you can see I apply a plateau test here. Here is plateau test. And I fabricate an appliance to clip on the plateau test. So I can apply the distal force, intrusive force from buccal and plateau. Intrusive force from buccal and plateau. So I can get the intrusion of molar to get some counterclockwise rotation of mandible. The progress, keep space closure. And here is the progressive cephalogram superimposition. You can see some counterclockwise rotation. And also, the torque control. But here you can see, I check the CBCT and I can find the mean screw in her mouth. The mean screw installed in the prior treatment, I need to remove. Otherwise, I cannot move the molar because there would be some interference. So I remove the mean screw and I install a new one at the infrazygomatic crest because I try to avoid the root contact. So I intentionally use the extension, wire extension to from the infrazygomatic crest. So I can intrude the molar, and from buccal and also from palatal, so that I can maximize the vertical Here is the progress. I continue to close the space. I continue to close the space. And here is the most recent photographs. Here you can see the profile change. The profile change. She had no gummy smile, but she was a case with vertical maxillary excess. So I tried to intrude the whole upper arch, to enhance vertical control and rotate the mandible counterclockwise, so that I can improve her facial profile by active vertical control like this. So this is my answer to your question. I hope that this will help.
Thank you very much. Thank you so much for answering with sincerity. Thank you.
Thank you.
Doctor.
Thank you, Professor. Thank you so much for today's lecture. There were so many amazing cases. And Professor Tae Kim is my supervisor. I'm so glad to see him here. And I have one question. In the case of severe protrusion, I'm curious about how you maintain the torque of anterior teeth while space closure. You did a lot of retraction of anterior teeth, but the inclination of the anterior teeth looked good in the debonding photos. How did you manage it? Do you usually use talking spring or something else?
Okay. Initially, I tried many cases with talking spring, but recently I seldom use talking spring because I believe I just emphasize the talk after I close the space. I believe you will close the space on rectangular stainless steel wire. So it's just basic torque control. It's just basic torque control. But after we close the space, I start to use the because my bracket is 018. So I shift to 17 by 25 TMA arch wire to apply the plateau root torque in the front segment. In the front segment, around maybe 30 to 40 degrees plateau root torque will apply. But at the same time, I will still hold the anterior teeth with the the mean screw anchorage. So the anterior teeth will not flare, but the root will be moved plateauly. Basically, that's the way I control the incisor torque. But you need to know, because I use a lot of anterior tests, so during the space closure, there would be an intrusive force. There would be an intrusive force in the front. And in the front, it is in front of the central resistance of the upper incisors. So there would be a moment to flare the upper incisors. But actually, the incisor tip will not move forward. So the roots will move plateauly. That is another way for my torque control. So with the anterior test and arch wire bending on 17 by 25 TMA arch wire, I believe that is the way I control my upper incisors.
And do you use TMA wire without loop or just?
Without loops.
Without loops.
Without loops.
Mm-hmm.
Yes.
Okay, thank you very much.
Thank you.
Okay, thank you for answering. And I have some question with me. Kindly answer shortly to the question in order. If you have no idea or can't understand about question, you can just leave it. Can you see this my screen?
Yes, I can see the screen. How to put the spherical mean screw? Actually, a vertical with a knife, surgical knife, a vertical cut then around 2 millimeters. Then I can insert the mini screw, initially perpendicular to the bony surface. And after initial engagement, I turn the mini screw. Okay, because I think, I turn the mini screw 45 degrees to the occlusal plane, and then insert it all the way to near embedded into the soft tissue. Then I stop. Then I ligate lecture wire cut from Kobayashi hook. That was, the size was 012 inch. So I use the lecture wire to ligate, to twist the lecture wire and make a lecture wire hook. Okay, it's easy. It's easier to see the movie, but I think it takes time. So I just use my words to explain the way I insert the mini screw. I believe many of the colleagues have seen the way I insert the anterior cervical mini screw, and also you can find you may find the video on my Facebook. So I think just like that, or I can send it or post it on the website on the Facebook. It's easier.
Okay. Yeah.
The same molar intrusion mechanics apply with the aligner too. Yeah, I believe the orthodontic tooth movement, they are all the same, right? The basic biomechanics are all the same. So I think if you can apply the force from buccal and palatal, we can achieve the active vertical control with the fixed appliance or with the aligners. If we can apply, but I believe tests, because if without tests, I don't think there is active force enough to intrude so much. Although there might be some effect, but I think that would be different. So this is my second, my answer to the second question. Maybe of course there are limitations, but the limitations might be different with the aligner or with the fixed appliance. It is because of the appliance design. Depends on appliance design. In terms of force system, I believe that is the same. What is the working arch wire while starting total arch utilization? I think I usually use 16 by 22 stainless steel arch wire as my working arch wire. But if I complete the space closure, I will shift to the 17 by 25 TMA arch wire. So it is also possible to use the 70 by 25 TMA arch wire as the working arch wire while total arch digitization. I think that is fine. Okay, do you prefer put only one test instead two tests for true upper incisors or correct gum smile? If one is enough, I would insert only one mini screw instead, because if you look at my cases, most of the anterior tests, I put only one test in the middle, and some doctors worry about the smile arc. I don't think the smile arc is not controlled by the test. It's not controlled by the test. There are many ways you can control the smile arc. I think it depends on your philosophy or your biomechanics. It's not about one test or two tests. I think basically it is the same. And I myself prefer one test in the middle. And what size of the mini screw you put in the lower and upper anterior? I put 2 by 10, because there is no vital structure there. So I usually insert 2 millimeter in diameter. Because I seldom pre-drill. I do not pre-drill, so I just insert the mini screw by self-drilling. So I used 2x10, and it was made of stainless steel. It was made of stainless steel because it's sharp and it's strong, not so vulnerable to broken. Okay, what about tongue space? It will become compromised if you will retract full arch much more. Yes, I think this is a very good question. But in my belief, my personal belief, I think there would be a balance. There would be a balance between the force and the tongue force. I mean, there would be a balance between the force system of our tooth movement and the tongue force. Tongue was there. Tongue is there. If the patient complains of the space restraint of his tongue or her tongue, then we can start protract the molars. Do you see my point? I mean, naturally, it will restrain our tooth movement by force balance. If not, if the patient start to complain about the tongue space restraint, then we can protract the dentition to fulfill her or his requirement. So that's my thinking. So to the next, what is the available limit or available housing in which you will decline to treat? Okay, I think you can see there are so many cases, might be surgical cases. If we can treat it by surgery, surgical orthodontics, it would be much more easier. It takes time, and it was horrible during the treatment because you do not know what the treatment result would be. So before the available limit or available housing limitation, I think it's about our willing. Actually, I do not want to treat these cases without surgery, but patient ask, and sometimes we will agree. But if you try to agree the orthodontic treatment with this kind of patient, you had better discuss with the patient with the understanding. There would be compromise. There will be compromised treatment results because the skeletal was not changed at all. And what we do is only dental compensation. And of course, we will control everything we can do to minimize the side effect and also the maximize the orthodontic potential to maximize the treatment results. But however, every case is different. You can see I closed so many spaces, so large spaces in some cases. But however, you will come across some other cases, very, very difficult. There might be only one factor different, but you may overlook the critical one. You may overlook the critical one. But I need to say, just like extreme sports, it's dangerous. It's dangerous. So auto transplantation needs a good access. Do we have access for this kind of surgery when the canine is so high? Of course not. Of course not. That canine cannot be done, cannot be solved by auto transplantation, because the colleagues who transferred this case asked me if we can try the canine transposition in the case of canine ankylosis. If that case cannot be if that canine cannot be moved successfully with the after subluxation, the next step we should do might be destruction osteogenesis. Destruction osteogenesis. That means we need to cut the bone and move the bone segment downward to its position. Do you get my point? Auto transplantation needs good access. The access, of course, you have seen my cases of some mutilated dentition. You need to move the other teeth to arrange the space suitable for the auto transplant, and you had better make sure this case is this space is the best place for the auto transplant. Otherwise, what if the auto transplant got ankylosed after auto transplantation? Actually, there are 2 points I mentioned. One is the canine ankylosis case. I subluxate and move the canine. That case cannot be done by auto transplantation. That needs destruction osteogenesis. And for mutilated dentition, it's quite troublesome. You need to move the other teeth so that you make a proper space arrangement, and then you can start the auto transplant. So that's why I do not auto transplant these 2 teeth at the same time, because the time sequencing is different for each auto transplant. Okay. Yeah. Hello, Mark.
Yeah, Mark.
Great to see you here.
It's attending today's webinar now.
Yes.
Okay, thank you for answering the question kindly and patiently. That's all the question I prepared today. We have time is flying, 2 hours. We will wrap up the webinar if there are no further questions. Thank you everyone for your support. WEBCEPH X have prepared something as a sign of gratitude. It is a certificate of appreciation. We are really impressed by your effort to share your valuable knowledge with the world. Well, Dr. Johnny Liaw, do you have something to say to the attendees before ending?
Thank you so much for the kind invitation and also this certificate of appreciation. And I'm very happy to give a talk here and share my thoughts with all the colleagues. I'm very happy to be with all of you. Thank you so much. And I'm looking forward to see you in person next time. Thank you.
Thank you very much. Thank you very much.
Thank you very much, Professor.
Thank you.
Yeah, we really end today's webinar at this point, and it was a meaningful time for me and the members. Thank you everyone for attending today, and special thanks to Dr. Johnny, our good speaker. Hope everyone stays safe and healthy until we meet in our next webinar. Goodbye. Thank you very much, Professor.
Okay, goodbye.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.